I'm one of the founding partners of Broadreach Healthcare. Started the company with Dr. John Sargent, who was my best friend from medical school. And we had always dreamed about creating a company that would really make a difference and bring the best of public and private sector together. And this was, we felt, was the opportunity, and we sort of launched it. The GP down referral model allows you to utilize all existing health capacity in a country, whether it be in the public sector or the private sector, and make it available to the benefit of all. So in simple terms, for example, right now if I'm a poor person living in a slum and the nearest health provider to me is a private clinic, I can't access it. What we've been able to do is basically create a model whereby now that person from that poor community can walk to their nearest private provider and get a basket of services. And what we've done is we've organized other private players to provide all of the different supporting aspects of what this person needs. The lab tests that they can get by the nearest provider as well. The informational IT backbone services that are required to monitor the results of this individual. So what we've done is we've partnered all of these people together and then conducted like an orchestra so that you get seamless service delivery for individuals who, in this particular case, would otherwise not have access to those quality of services. We were asked either to take people from the queue and move them into the GP model before they died, because they're not going to make it through the queue to get into the public sector hospitals at the time, which were just launching antiretroviral therapy for the first time, trying to train their doctors, trying to grow capacity. So the queues were enormous, and yet at about 3,000 patients, hospitals would be at capacity. They couldn't bring in more patients because they're just managing the revisits of those who they have. So people in the queue would be dying because the hospitals were clogged. So we either took people from the queue before they died, or we helped offload the stable patients to allow new people from the queue to come in and actually get treatment. And so our model became like a pressure release valve that basically was able to allow the system to scale up in a multiplicative way. Otherwise it would have been stuck at 3,000 patients and everybody else who had lined up would have died. Here we are trying to treat 85% of the population with 50% of the capacity of the country, and not in a systematic way using the other 50% of the capacity that's just kind of sitting there. So very simply, our logic was that if there's a way you can unlock that 50% that you're not using and bring it to bear, we think that you'd get much better equity of healthcare service distribution in the country. And then at that point, assess the gap you still have and then launch development efforts against it. It was, in a way, from our side, a no-brainer, but also from the government side, it was clear that this could really be of great value to them because it relieved a critical bottleneck at a time when they needed it the most. It's rare to me that so many different team members come together and truly play their parts in such an amazing way. And I say it's amazing because of the results. Above 90% viral load suppression at 9 years, which is unheard of in terms of the normal statistics of a population on treatment for 9 years. You're lucky if it's 50, 60% who are suppressed at this level in comparable data. So this is testament to the teams, the team really working well together as a team.